All right, so real quickly what I want to do is just take a look at some of the spinal nerves. We've talked about the central nervous system. This is really kind of the last one that's related to that. Everything else from here on out will be autonomic is what we'll deal with next. But the spinal nerves, we've talked about how there's multiple pairs, 31 pairs that are going out there. And again, really almost all these pairs are going to go and hit a specific segment of the skin in terms of sensation. Again, we know they're paired nerves in terms of motor and sensory on each side of the pair. And this is true of all of them except for C1 are going to some type of area of the skin. So what we call this is a dermatome. So you can see the dermatome here. This is showing you these different nerves and which regions they are actually going to be providing sensation to. Dermatome map is what they call this. And you can see C2 all the way down through the lumbar and the sacral nerves. You can see where they're kind of going to, again, not just as it works down there, you can see some of them like C6, C5, C7, C8 are supplying stuff in the hand. And you can see the sacrum as well as the lumbar are doing the front versus the back of the leg. So it is not just the highest one goes the highest part of the body, the lowest one goes the lowest part of the body. Again, this is a way for a lot of times a doctor or somebody like that to indicate whether or not you've had damage to some type of spinal nerve is if you have sensation loss in certain areas, this is going to be able to actually be mapped back up to which spinal nerve it is going from. So if you were to have a spinal cord injury, for example, they might test your dermatomes on the skin and they can kind of determine where that damage was at based on what you can feel and what you cannot feel. Some of these, again, also involved in visceral pain, as it's kind of talking about here, in which nerves they will be going back through. Again, I'm not expecting you to have it mapped out and know which one's which. The main thing with this one is kind of showing you a little bit further out on this. So you can see the spinal cord, we've talked about that, and the dorsal and the ventral roots and how these are paired nerves, but you can see there is what we have, this anterior ramus, which is going to the front of the body, as well as the posterior ramus, which is a branch off of that going to the very back of the body. And that anterior ramus is going to wrap around to the front of the body, depending on where we're talking about, as well as you can see some communications with the sympathetic trunk when it comes to some of the autonomic nervous system. One of the other things I wanted to kind of point out, and we mentioned it a little bit already, but is this idea of a nerve plexus. So where you get certain anterior rami of these nerves, they will form branches off of this, and both on the left and right side of the body will do this kind of reorganization where some of, let's say, C3 and C4 and C5 might be intermixing with one another and then can provide innervation on the arms, for example. And we're going to see that there is 4 main plexuses, which plexuses, it still sounds weird to say, but there's 4 main ones there. You have the cervical, brachial, lumbar, and sacral plexuses. And again, these are branches, groups of axons off these anterior ramus that are kind of re-situating themselves, and these will become a lot of the named nerves of the arms. Things like the medial and the some of these other nerves there, the medial, radial, and ulnar nerves, for example, are going to be going through here, and this is where they reorganize up in that brachial plexus. What this kind of means, though, is if you have damage to a single spinal nerve, it doesn't mean a whole area of innervation. So, like, by the fact that we have 3 or 4 spinal nerves controlling the hand, it means if you have damage to one spinal nerve, all the hand isn't gone. So, again, I always kind of say it's kind of like the nervous system not putting all of its eggs in one basket. And like it says there is certain spinal nerves that do not form plexuses. So intercostal ribs, for example, these are T1 through T11, not a lot going in there. A lot of these going through the intercostal space. The cervical plexus, and again, I'm not going to kill you on this stuff here. I would rather you know what the different plexuses are. If I show you an image of them, where they're at, I'm not as keyed in on knowing exactly which spinal nerves are contributing to which plexus as much. I don't want to give you a multiple choice saying, is it this, or this? But the cervical plexus is mainly C1 through C4 with a little bit from C5. And again, anterior neck muscle, skin of the neck, portions of the shoulder, as well as a branch of the what's called the phrenic nerve. So the nice thing about this one is this innervates the diaphragm, so we don't have the branches of that going through the spinal cord, which means you could have an upper spinal cord or neck injury that may not damage your breathing muscles, which is kind of a key thing. Where if it was coming out at the thoracic vertebrae, any neck damage would generally be a lot more times fatal because you would stop breathing before they could stabilize you. And this is kind of, again, showing you that C1, C2, C3, C4, how branches of axons of these are intermingling and forming these more main nerves, one of which is the phrenic nerve here at the bottom. The brachial plexus is then from that C5 through the T1. This is doing a lot of kind of the arm and hand. And you can kind of, again, see these three are going to become those main nerves. The median, axillary, radial nerve, ulnar nerve are really going to be the main nerves coming out of this. And you can see how those plexus here goes to three main nerves going through the axillary region. You get four main through the brachial region right here, and then it's going to be what's doing all the innervation down in the hand and everything. So again, damage to one of those spinal nerves does not mean your whole hand stops functioning. You might lose a finger or two, but you can still maintain a lot of the movement on that if we were to go back and look at the dermatome. The lumbar plexus is after a lot of these thoracic vertebrae, so that T2 down through T12, really not forming plexuses. Lumbar plexus is L1 through L4. It's doing a lot of kind of anterior side of the leg, but we do have an anterior and posterior division. But you can see right here, these are going to become a lot of those main nerves of the front of the leg. So like the femoral nerve, for example, would be in that. Probably the biggest nerve coming out of that. And you can see again how this is intermingling branches out of all those different spinal nerves. And again, doing a lot of the anterior of the leg, down the front of the shin even. Where the last one is the sacral plexus. So this is just below the lumbar plexus. Innervates a lot of the gluteal region, like it says there, genital region, as well as going down and doing a lot of the posterior part of the lower limb. And again, a lot of this is becoming one of the biggest nerves in the body, which is that sciatic nerve. It's actually parts of all these kind of come together. Sciatic nerve is huge. If you ever have a chance to see one, we won't get to dissect this time, but the sciatic nerve, I mean, it's big. I mean, I've seen cadaver dissections where they can grab it. It's like the thickest harpcord string you could think of. It's huge. And you see this is going down mainly the posterior part of the leg. This does go through muscles. If you've ever heard of having sciatica, that is sciatic nerve pain that radiates down the leg. It really is not comfortable.